This is Chapter 9, Assessing Pain, the fifth vital sign. So some of the definitions of pain include an unpleasant sensory or emotional experience. But whatever it is, we know pain is whatever and wherever the person says it is. The Chapter 9 objectives include identifying pain as the fifth vital sign, explaining the pathophysiology of pain, classifying pain into acute and chronic pain, knowing the different physiologic responses, discussing a physical assessment with somebody who's experiencing pain, and also considering an older adult and their experience, and then discussing the purpose and uses of pain assessment tools. So we know that pain is often undertreated. Pain is considered the fifth vital sign, and so we know that the pain causes a lot of physiologic responses, and so we are monitoring that, assessing and reassessing. Inadequate treatment of pain causes stress in the body, and so there's all kinds of impact from that. So some of the standards of pain management are by our accrediting bodies and the Board of Nursing, etc. The patient has a right to pain assessment and reassessment and appropriate pain management. The patient should be screened initially and periodically for pain, and that any of the values should be reported. So this requires to have evidence-based tools to base the reporting on, and also maybe some subjective data from the patient. Pain management requires education of staff of standards for the hospital and support in the designing organizational policies to help meet the objectives of patient care. So we would educate the patients and families of their rights and what the expectations are, what the pain management plan is. The patient should be a part of that as we address their needs and collect data to continually reevaluate the effectiveness of the plan. So the pathophysiology of pain includes the source of pain, stimulating peripheral nerve endings or the nociceptors, and then they transmit these sensations to the central nervous system. So the sensation of temperature, heat, cold, pain that's distributed in the body or skin is detected as pain in the periphery, and it's transferred to the central nervous system. So pain can be stimulated by trauma, injury, some tissue damage at the site. Those chemical nociceptors respond to those things. So there is the transduction, that's the stimulus, then the transmission of the impulse to the brainstem, the perception of the brain, the awareness of the sensation in the parietal lobe, and then the modulation, which can change or inhibit pain message that's relayed in the spinal cord. So all of those pieces are parts of nociception. So the physiologic responses to pain could be anxiety, fear. Chronic pain can cause depression and suicidal thoughts. Acute pain a lot of times is severe and can cause pain, crying, moaning, grimacing. Chronic pain and some acute pain in different populations can cause decreased thinking, judgment, confusion. We know the physiological responses of stress and pain in the body is increased heart rate, blood pressure, respirations. Think of the fight or flight as your body is trying to race to help what the problem is. The other things that the body doesn't absolutely need to survive at that time are blood is shunted away from those things. For example, the intestinal motility, urinary, the bladder. So urinary retention sometimes happens. The blood sugar or glucose goes up in times of stress, again, in that fight or flight response. So some of the pain classifications that are important is acute pain and chronic pain, and additionally cancer pain. So acute pain is recent, new onset, chronic is greater than 6 months. You would also want to know what types of locations of the pain. Visceral pain would be abdominal cavity, thorax, cranium. Parietal is ligaments, tendons, bones, blood vessels, and nerves. So again, that acute and chronic pain, differentiating between those. Acute is short term and should resolve after the injury. But that chronic pain can last 6 months or longer and doesn't necessarily stop after the injury, recovery of the injury. So some of the nonverbal behaviors for acute pain, typically it's sharp, guarding, moaning, grimacing, can even be those change in vital signs like we talked about, those physiologic responses to pain. Now, chronic pain has adaptation. Your patient gets used to dealing with some level of this pain every day, so they start diminishing activity. Maybe they might have some irritability or problems sleeping at night over long periods of time because they're waking up in pain. Now, cancer pain, we know, could be sudden or severe. Cancer pain can last for a very long time because it's related to blocked blood vessels or from the mass or inflammation in the area. So that nerve pressure from the tumor or inflammatory response in that space can cause cancer pain. Now, depending on how early the stage of the cancer is, this could be severe or could be chronic neuropathic type pain where there's sensation issues along with this cancer pain. And it may be related to the cancer itself, but there's also some inflammatory response dealing with surgery for cancer, radiation, and chemotherapy. So sometimes the pain is related to the mass itself or could be related to the treatment. But what we do know is that many patients experience cancer and it can be severely undertreated because just like for many patients, they get a physical tolerance over time to a level of pain medicine, and it might require more and more medication to keep them comfortable. So this is definitely a severely undertreated situation. Now, there's other types of pain, radiating pain, which means there's pain at the source and then it extends away to other locations. Referred pain may mean it is occurring on one location away from the pain source. Phantom pain is those nerves that are left after an amputation or paralyzed body part still may have pain and sensation to them. And then intractable pain is just pain that is not relieved by any measures, that high resistance to pain relief. So here are some areas of referred pain. We talked about this in abdomen, that you have a referred rebound tenderness test. Where if you press on the left lower quadrant, you feel it on the right. And that we're assessing appendicitis there. But there's other spaces too. For example, if somebody is having stomach issues, sometimes they might feel that in the middle of the back. Or if they're having chest pain, they may feel it down the left side of the arm, not just over the heart. And so those are areas of referred pain. Now, neuropathic pain is abnormal processing of that pain. We're dealing with peripheral nerve, central nervous system, those types of spaces. So it can be very difficult to treat. It can happen after healing. Sometimes it's inflammation in the area that affects the nerves. That nociceptive pain can be difficult to control. For example, there's diabetic neuropathy, shingles, HIV or AIDS, sciatica, trigeminal neuralgia, that's facial pain and nerve issues. phantom limb pain, and pain from chemotherapy. So some of the dimensions of pain include physical, which are anatomic structures, sensory, which are those sensations, the pain, numbness, tingling, those quantitative descriptions of pain. Behavioral is verbal or non-verbal behaviors, grimacing, um, those type of moaning, those type of things. Social and cultural backgrounds, maybe how somebody is dealing with the pain in their culture. The cognitive dimension of pain is the thoughts, the beliefs, the judgments, or the motivations, how somebody thinks about the pain. The affective is the feelings or the emotions. I'm sad, I'm angry, I'm happy. That's the affect. And spiritual is a meaning or purpose related to pain. Um, the pain affects my aspect about life or my thoughts about life, um, uh, those type of things, or higher power in relation to pain is a spiritual dimension. So some of the pain tools we use for assessment includes the visual analog scale, the numeric pain intensity scale. The numeric rating scale is one that we commonly use in the hospital, rating your pain on a scale of 0 to 10. So when you are looking at these tools here in a minute, you may see those as familiar. So different cultures respond to pain in a different way. Some people note pain as a weakness, and so, but what we know is that with pain and stress, we have physiologic impacts on the body. And so minimizing that to the best of our ability is very, very important. But some cultures may address that in a different way and may try to do those in more of a homeopathic way. Like meditation or things like that instead of actually taking pain medicine. So it's important not to stereotype people for how they're managing their pain, but look and see, what do I think about pain and my own responses to pain? Do I respond verbally, loudly? Am I stoic about my pain? Um, and start thinking in that way, because everybody treats pain a little bit differently, and we want to be respectful and help meet people wherever they are. So when I talk to patients, I ask them, how do you typically treat your pain? What works for you in treating your pain at home? And then let's start the discussion from there. So some of the barriers to pain assessment, like I said, is that some patients believe it's weak to complain about pain, or they think that pain is a negative thing that's happening to them. Or it may mean that things are getting worse, that medications are addictive, and so they don't want to start taking pain medications if they're going to get addicted, or that pain is just part of life. Um, there are some physical conditions as far as specific things that cause pain, and some patients may just accept that as if they have this, they are going to have pain. So us as healthcare providers need to note that if patients complain about pain, that does not mean they're necessarily drug seeking. They have a problem. We want to manage our own bias in that way, because that can be a real challenge. Now, do we have to have physical or behavioral signs to validate pain? No, we do not. If the physician orders pain medication and it's safe for the patient to have it, then that should be all we need if they are requesting that. Um, Sometimes nurses want to um, have the patient validate their pain. Well, you're not crying, or you're not moaning enough, or you don't look in distress, so that means you must not be in pain. And that is not the case. Pain can be experienced by older people, by children and infants. and they all express that pain differently. So it's important to have the conversation with the patient about how they manage their pain, what their pain feels like to them. It's worth a discussion. So if your patient is sleeping, that doesn't necessarily mean that they are not having any pain while they're sleeping, um, but they just may be exhausted. So that's people can still have pain while they're asleep. We do have to be careful when we give medication, that we are safe and we are not depressing their respirations that might cause them harm, or lowering their heart rates and blood pressure. So we do have to be safe, but that doesn't mean that all medications are going to depress the respirations. We have to navigate these things safely, but sometimes the patients might believe that. So we need to have this discussion with them and make sure they're educated in what needs to happen. Um, the other thing is only giving medications at night so the patients will sleep. That is not necessarily helpful. Getting a good level of pain control all during the day will help them be relaxed overall. You don't want to wait until somebody's in crisis to start treating their pain, because it's a lot harder to get on top of after that. So there are special populations we have to take into consideration. Not every patient is going to be able to tell you I'm a 2 out of 10, because they are nonverbal. Either they have dementia or cognitive impairment. So with those type of patients, we look at their responses. Are they guarding? Are they crying? Are they moaning? Are they restless? Those are definitely things that we would want to look at. So for your nonverbal patients or ones with cognitive impairment, you're going to try to ask them if they're hurting, if you can find out why somebody might be hurting in a specific place, or those type of things may take you investigating a little bit. But we're really going to observe their behaviors. You can also talk to the family. If the family sees them on a regular basis, they may know, okay, when my family member is doing this thing, this means that they are hurting. But the patient telling you themselves is always a priority. After you provide the pain medicine, then you're going to reassess and see if there is any relief from that pain medication as well. So again, self-report is always best. We use the cold spa, where your patient answers our cold spa questions. When we talk to them about their pain, try to have the open-ended questions where they can provide you the most information, um, uh, as well as how their pain management. Are they able to get up and move around and uh, go to the bathroom, things like that, um, with their pain level if they're having any issues there. You never want to put words in the patient's mouth, but sometimes when you're describing pain, you might give them a laundry list and then let them pick from the words. But I always talk to them about their past experience, and whatever your patient has been working with or believes their pain is. I really try to work with them from that point. So again, the pain assessment tools are based on what we need, the standardization, and we involve the patient in these so they know they're part of the assessment. So you have your numeric rating scale, your FACES pain scale for cognitively impaired adults, and then you have a universal pain assessment tool. So here's your visual analog scale, your numeric pain intensity scale, and then just a simple descriptive pain intensity scale. So we use the numeric pain intensity scale or the rating scale when we ask the patients, where are you having pain on a on a scale of 0 to 10? Then this is the universal pain assessment tool that you might see frequently, the faces, which face do you connect with? And that's common as well. Some of the objective data we utilize is we're looking for the patient's posture. We're looking for any facial expressions, eye contact, things like that. We're assessing if they are relaxed or if they appear to be guarding, especially any joints and muscles, if they're having had an injury. We observe the skin for any painful scars, lesions, rashes, etc. Any bruising or edema can cause pain. We're assessing vital signs. All of these things, as we know, are physiologic responses to pain. So if your patient is having these responses, we might, uh, especially if there's acute changes, we might talk to them about their stress and pain level. So the nursing diagnosis that we might utilize for these patients are the acute pain, which is a new onset, or chronic pain, which is greater than 6 months. But here's an example of these nursing diagnosis sentences. So in summary, we identify the pain as the fifth vital sign. We know the pathophysiology of pain, the acute and chronic pain, and all the different physiologic responses. We know that the pain requires a physical assessment for adult and older adults, and that you would want to find your pain assessment tool that best fits your patient's needs.